This is Benjamin Boyce, and welcome to my ongoing series on gender, sexuality, and transition. Today's guest is Dr. William Malone, who is an endocrinologist. Endocrinologist. Not to be confused with a rabid hater of Star Wars' third episode or sixth episode, indoor cringeologist. Anyways, here's William Malone. How's your day going so far?
Yeah, not too bad.
Yeah.
This whole topic is a difficult one, um, and I think a lot of physicians have some significant frustration at how, in particular, our medical societies have handled this topic, especially in the U.S. And I think that's caused quite a bit of frustration. So I think most doctors are usually baseline stressed. Physician burnout is, I think, at all-time highs. But this topic in particular is obviously is a stressful one in and of itself. So, but the day's going pretty good. How's your day going?
Oh, it's pretty good. I mean, I was just going through the report that you sent me on this, and
Yeah.
just cranking into livelihood.
Okay.
But you brought up that it seems like a vicious circle that this topic, which would be, I guess, transsexualism or
Yeah.
transgenderism, uh,
Correct.
it it introduces stress to caregivers, medical doctors, and therapists, which causes
Patients.
them to, let alone the patients, but it causes the professionals to avoid it, leading to less quality of care for the patients. Um, and then the people who step in to give the care usually end up being, would you say, affirmative or only going in
Yeah.
one direction?
Yeah. No, I think that's a great point, and that's exactly what's happening. So if docs don't have an understanding of the topic, they will essentially just steer clear of it, and they'll direct a patient who is um, requesting puberty blockers and cross-sex hormones to a so-called gender expert who may or may not be an expert.
Hmm.
They may just be willing to prescribe cross-sex hormones. And so that doc who has little understanding or may be extremely skeptical of gender affirmation therapy will refer to a doctor who will, quote unquote, give the patient what they want. And that obviously, yes, it has led to the current situation where most docs are not speaking up because they don't feel like they have, I think, the medical knowledge to do so in a competent fashion. Because this, so historically, the number of people who would go on to cross-sex hormones and I'll call it feminizing or masculinizing surgery was very small. It was maybe one out of 20,000 in the general population, one out of 40,000. And, it was basically considered an orphan disease
What do
or
you mean by
condition,
that?
meaning it's very rare that you
Okay.
you hardly see it and hardly anyone is specialized in it. But with the introduction of puberty blockade in particular, and then the new phenomenon of adolescent onset gender dysphoria. So I'll call it adolescent or young adult onset gender dysphoria. Essentially, this has exploded into um, mainstream medicine now, and most doctors are completely unprepared to deal with it. Um, in the UK, it's a little bit different now. So Carl Hennigan has come out, and he's the editor in chief of the British Medical Journal. He came out earlier this year and essentially stated the truth, which is gender affirmation therapy is unproven to work and uh, has the risk of significant, serious, and irreversible side effects. and he essentially stated that it is unproven and unsafe to be applied to children and adolescents. And then recently, the Royal College of General Practitioners, that's a group of 50,000 general practitioners in England, in the UK, came out recently with a statement essentially stating the same thing, which is the truth, which is this approach to treating folks with gender dysphoria, this gender affirmation therapy, and in particular, and then the application of the medical arm of the Dutch protocol, which is puberty blockade at Tanner stage 2, early puberty, followed by cross-sex hormones, and then potentially sex reassignment surgery. So that is completely unproven in children and adolescents, unstudied, unproven, very dangerous given the side effects of these hormones. And in addition, the application of that protocol to, because most gender dysphoria resolves. So most kids
By
with
age
gender
20,
dysphoria,
you say?
yeah,
80%.
as that's what the literature says. So regardless of source, this has been well established back to probably 1995. And again, we're talking right now about childhood gender dysphoria. So 80 to 90% of kids who have gender dysphoria will have resolution of that as they pass through puberty. That's not been well studied. We don't know the process by which that occurs, but we do know through puberty, the majority will resolve. So if you apply a protocol of puberty blockade, so affirmation, puberty blockade, and cross-sex hormones to every kid who's coming into puberty, you essentially are going to treat many who would have resolution of their gender dysphoria. And that's another major, obvious problem.
Well, what are the basic effects of the puberty blocker and then going on cross-sex hormones? You said that was dangerous, or they can be dangerous. What are some of the effects of that?
Yeah, so puberty blockade, essentially, the idea is that if you have a gender dysphoric kid, you give them puberty blockers, it will buy that kid some time to figure out if they want to be treated with cross-sex hormones. But puberty blockade, and this has been written about fairly extensively in the literature, especially the international literature, essentially halts the development of that adolescent on multiple levels. So physiologically, socially, perhaps intellectually, we don't know.
Okay.
So essentially you're halting a natural process of development. And so after 2 years of puberty blockade, so let's say you start a kid at age 14 on puberty blockade, 2 years later, you're essentially still dealing with a 14-year-old.
Huh.
Socially, all of their peers have advanced.
Yeah.
They're having more complex interactions. They're going through puberty. They're having all of they're experiencing all of the things that occur during puberty. And that process seems to resolve most gender dysphoria. And so you're halting one criticism here, and this is not just my criticism, this is what's written in the literature. One concern and criticism of this approach is that you are halting the process that actually leads to resolution of the dysphoria. Now, there's one major study of about 70 kids who showed, and what that shows is that all of those kids who were put on puberty blockers went on to cross-sex hormones. So puberty blockers are sold as a way to decide.
Huh.
But if you are halting a child's development, how are they supposed to decide? And so all of the kids in that study went on to cross-sex hormones. And that combination of puberty blockade followed by cross-sex hormone has a high likelihood of causing infertility.
Okay.
All right. So that's one major issue here. If you initiate puberty blockade early in puberty and then follow that with cross-sex hormones, you've essentially induced this state of permanent infertility.
Does that not just fertility, but sexual gratification, like the sexual development, the ability to have enjoyable
Yeah, yeah,
sexual contact, is diminished
yeah,
too?
yeah. That's another concern, right? Because you have essentially immature genitalia.
Okay.
Yeah. And then there are significant risks of cross-sex hormones. So a girl who is given testosterone. So let's say, puberty blockade is initiated at age 14 or 13, and then cross-sex hormones initiated at 15 or 16. So within 3 to 6 months, her voice will deepen permanently and not return. She'll experience some changes in facial structure. So her jaw will increase in size. Her brow might change. Her face will begin to appear more masculine. There are changes in skin and hair, obviously. So testosterone tends to cause body hair growth and reductions in scalp hair growth. There are reports, and again, we don't fully understand what happens here. And this is why Carl Hennigan has stated very clearly, he said, this process of puberty blockade and cross-sex hormones is being used, and this is his words, in a state of profound scientific ignorance. So we don't know exactly what's going to happen. We have some experience from women who have developed testosterone secreting tumors. So if a woman comes into
naturally,
yes. So
okay.
So endocrinologists are supposed to identify excesses or insufficiencies of hormones,
Okay.
and then put those back into normal ranges. That's our primary goal. That's our primary training. So if somebody's insulin levels are too low, their blood sugar will be too high. They will have diabetes. We do things to get their insulin levels back to normal ranges. So if a woman comes in with excess testosterone, this is a significant, in normal situations, this is of significant concern. I mean, we start a workup. We're doing a ton of blood work. We're doing imaging. We're trying to find this tumor that's making testosterone because it's going to permanently alter her physical appearance and massively increase her risk of heart disease.
Okay. And so what does it do to the female genitalia?
So it'll cause vaginal atrophy, and that can lead to incontinence. And that's a significant side effect. Okay. So the vaginal tissue essentially is dependent upon estrogen for normal function and sustainability. So there are immediate physical changes, and then really long term, a profound increased risk in the chance of heart attack. And we do have studies showing that. So a woman taking testosterone has 4 times the odds of developing a heart attack than a woman who is not.
And is that because the way in which the female, the female grown heart interacts with a new induction of testosterone, or does it bring it in line? Does it bring these women in line with the male rates of heart disease?
It's twice the risk of the male rate.
Okay.
So so I want to be careful with the statistical terms here. So the correct term, the way the study was done, it was odds. So it was 4 times the odds of a woman's risk of heart disease and 2 times the odds of a man's risk. So it's higher than both. So a woman taking testosterone basically has a higher risk than both categories. That probably has to do with a multitude of factors. So, right, every single cell of our body that has a nucleus has either an XX or an XY chromosome in it. And each cell behaves according to its complement of sex chromosomes independently of hormones. So it's not like we're all made up of ambivalent cells who will respond simply according to the bath of hormone that you put them in. There are sex-specific differences. This is well known in biology, not well known by some people in gender clinics, I found out. They think that, well, if you just put a woman's testosterone level into the male physiologic range, that her body will just act as if she's male. So her risk will just go to male levels, but that's not true. In addition, the way that our DNA expresses itself is also sex dependent in terms of what genes are turned on and turned off. So there's a host of biological differences that some of them are poorly understood. But certainly it should be no surprise that if you take a male hormone and put it into female physiology at excess levels, that bad things are going to happen. Mm-hmm. And then the reverse is true as well. So a man who takes estrogen, after about 5 years or so, his risk of developing blood clots and strokes is he'll develop. So men taking estrogen will develop blood clots and strokes at 2 to 3 times the rate of men not taking estrogen and women. So a significant increased risk of stroke and blood clot. We know this just from women who take birth control. That is the main issue with oral contraceptives is blood clot. So these side effects should shock no one. I mean, this is basic, at least for an endocrinologist, this is basic hormones and biology.
So you guys, endocrinology is being retrofitted to become, instead of something that aligns the body with its natural state, to like a kind of a mad scientist, we are now employed to change the body's natural state. We're now meddling with nature rather than to bring a body back into alignment.
Yeah, but only in this one particular condition. And that's why there's this cognitive dissonance. It's really bizarre. So
only for gender dysphoria.
Correct. So in every other aspect of medicine, if the mind and the body are misaligned, so if the mind is at odds with material reality, biological reality, or some other reality, we do everything we can to get that individual back to foundational reality. But in this situation, we're essentially changing the body to match the brain. But that paradigm is completely reversed, and as it should be in every other aspect of medicine. And that's why it makes no sense, because it doesn't make any sense. It's at odds with how we practice medicine and any other aspect. And that's why some have called this kind of a crisis of, psychiatry, for example, because if this principle holds that if the brain and the body if the brain is at odds with reality, but we reinforce the non-reality, there's no field of psychiatry left.
We just alter the body to suit the subjective whims of the mind.
Yes.
Which is good business if you're into body modification, plastic surgery, and handing out hormones.
Yes.
To be completely cynical. I mean that as a joke, but I don't think there's so much joking going on.
Well, no, I mean, I think there's certainly, unfortunately, some of that going on. I mean, I think, yeah.
And in the United States, so in Britain, doctors are standing up and coming out and making very firm statements. What is happening in the United States?
In the United States, the main medical organizations have endorsed affirmation therapy. Okay. And this was before the wave of adolescent onset gender dysphoria. Otherwise,
so this is mostly for adults.
No, so they endorsed affirmation therapy for childhood onset gender dysphoria.
Okay.
By the way, the Dutch National Clinic doesn't use affirmation therapy. At least they don't describe that in the literature.
And you bring up the Dutch clinic because they're the ones who made the first researchers that are the research that is now the foundation for
Yes,
affirmation.
yes. So their medical protocol, at least, okay, the puberty blockade followed by cross-sex hormones, but they don't use affirmation. So there are three different counseling models, essentially, or approaches to gender dysphoria. And I fault the medical societies for not educating physicians about this. So affirmation is only one. So there's a therapeutic, there's an accommodative, and then affirmation. The Dutch do not use affirmation because they understand that affirming a young child's gender confusion or sex confusion, right? To be more accurate, I would say it's a sex confusion, reduces the likelihood that that kid's gender dysphoria will resolve.
On its own.
Yeah. So they use what's called a modified therapeutic model, where they essentially focus on exploring developmental factors that could have led to this state of gender dysphoria, which the term gender dysphoria as well is bizarre. But anyway, so because no one comes in and complains of their gender usually, they complain of their characteristic features. So I don't like my secondary sexual characteristics. I don't like breast development. I don't like I don't like that I like football more than field hockey,
Yeah.
to use a stereotypical gender. Do you see what I mean?
Yeah, but until the spate of ROGD, rapid onset, or adolescent onset, which
Yeah.
now, which I think, I'm speculating here, but it seems in the cases that I've seen and the people that I've spoken to, they spend a lot of time online and they get this idea in their head that their gender wholesale is wrong
Yeah.
rather than
So
aspects.
yeah, I think that might be accurate. So we can touch on that. I want to go back to if you don't mind, to the three counseling models, just to finish that point off in case some people are interested. So the Dutch don't use affirmation because it prevents resolution of gender dysphoria. They use a modified therapeutic technique. It's called Ken Zucker was using a therapeutic model, which is one of the reasons that they came after him, because he was essentially trying to help kids resolve their gender dysphoria so they would not have to go through cross-sex hormones and sex reassignment surgery. Because the long-term studies show that in terms of psychological functioning, it doesn't help. It doesn't work. Suicidality is actually increased.
Hmm.
There was a Scandinavian study showing that folks who had undergone sex reassignment surgery had a 20-fold increased risk of completing suicide long-term than those who had not versus baseline, which is part of the motivation for inducing or introducing puberty blockade to the whole treatment protocol. Because one of the thoughts was, maybe the reason these folks are not doing well long-term is because they went through puberty, and so they look like their real sex, and so they're not able to present themselves as the opposite sex, and so if we can block their puberty, they'll do better long-term. Completely unproven. No long-term data to show that that works. And in addition, because most gender dysphoria resolves, that approach is catching many, many kids inappropriately. So Zucker was using a therapeutic model, and the Dutch use a modified therapeutic. Accommodative is essentially you don't take one view or the other. You don't affirm, but you also don't try to resolve. You're essentially hands off. So there are three different models. In the United States, we have combined affirmation therapy with the Dutch medical protocol. So, which essentially is ensuring, which is the puberty blockade, which is essentially ensuring that the maximum number of gender dysphoric kids are going to be caught up into medicalization. And so that's another criticism. I'm not sure how we got down that road exactly, but
And medicalization is a lifelong path
unless
unless you
you,
desist.
so desistance is essentially resolution of gender dysphoria, and then detransition would be after you've been medicalized. Stopping cross-sex hormones, attempting reversal surgery if possible, etc. So yes, if you go down that pathway, and it's a long-term pathway for you, yes, you are dependent upon medication.
You're in a sense a ward of the medical establishment then.
You are you're a permanent medical patient. Yes,
Mm-hmm.
yes. So testosterone injections, for example, they last about 2 to 3 weeks. So uh, if you're essentially if you're a woman taking testosterone, your testosterone levels will go to zero after about 3 weeks without an injection. So you're completely dependent upon hormones to maintain the state that the hormonal state that you're in. I should add one more thing too. So I believe the Dutch. So this pathway of medicalization is known to be risky. I don't think this is necessarily a surprise. But the approach to medicine is a little bit different in Europe than it is here. So in Europe, the approach almost is that you can decide to do something that is not good for you if you wish. You see that a little bit with assisted suicide, for example. So, okay, I have depression and I've tried everything, and so I'd like a doctor to basically kill me with medication. So that has been the approach as well, and you see that in the international literature where, okay, we know that cross-sex hormones and sex reassignment surgery are dangerous in and of themselves and probably don't improve long-term psychological functioning and may in fact worsen it. But because this individual wants to choose that road, we're going to facilitate that. So it's one of kind of personal choice. It's quote unquote a right to access something that is harmful. In the United States, we haven't really adopted that approach so much. So I think anybody looking at the literature and anyone with any experience prescribing these hormones knows without a doubt that this is a dangerous path. And even, I would say, affirmation supportive practitioners, if you really pin them down, will admit so. But they will default to, well, it's the patient's right to decide how they want to be treated. Mm-hmm. So there's really two parallel arguments going on. One is a medical one, and one is, is it a right to decide in it? There are people on both sides. Is it a right to access a treatment that is harmful to you?
Mm-hmm. I guess, and there's a cost-benefit analysis that people run through, but with the political situation and the push towards affirmative therapy or the affirmative model from outside the medical establishment, that can guide the patient towards doubling down and very much insisting that the risks or the benefits outweigh the risks.
Yeah, I think that's an accurate statement.
And do you feel in America there is not only are the professionals undereducated with this, but they're also under pressure to not speak out about this or to just go along? Do you feel that there's pressure or that there's risk for people professionally to stand up and to push back against the affirmative model?
Yeah, I think so. Yes, I think is the answer to both of those. I think so. I think in the general community, it's more of an issue of lack of understanding of what's occurring, lack of familiarity with the literature. And so when that happens, what doctors do is they default to guidelines put out by medical organizations. And so they'll pick up a document that is supposed to, in a scientific way, putting politics aside, summarize the medical literature to help that doctor make a decision about how to best help that patient. And that clearly has not happened with the Endocrine Society, the American Pediatric Association and the Psychological Association as well in this country. They have not presented in any scientific or objective fashion the full spectrum of concern about gender affirmation therapy. They have gone all in for affirmation to great consequence, to negative consequence. So yes, it's a lack of information. It is a failure of our medical societies to actually present objective. We can't get, I'll give you an example here. So, at the main endocrine meetings, occasionally there will be an hour presentation of a point counterpoint. For example, of a new diabetes medication. Okay, so you'll have one fellow here and one doctor here. So two doctors up there, and they will talk back and forth over the course of an hour with slides and literature and cost-benefit analyses and minutia you cannot even imagine. Okay? And they will pat themselves on the back at how smart they are and what a great conversation this has been. Okay?
Yeah.
And we can't get a point counterpoint on gender affirmation therapy.
On puberty blockers?
We can't get a public balanced, or we can't get any of that. It's essentially just a one-sided presentation. And so in a room of 1,000 endocrinologists, I mean, these are huge lecture halls. These meetings happen once a year. You'll have a gender affirmation clinician lecturing to 1,000 or so endocrinologists, telling them, essentially confusing them about sex and gender,
mm-hmm.
telling them that affirmation is the treatment, no mention of the accommodative or therapeutic models.
Do they cast therapy into the, do they frame it as conversion therapy? Do they go that far?
No.
Okay, they just
say this is how this should be treated now.
Okay. Now.
Yep.
So it's like by fiat. Just somebody's
Correct.
decided this in
Yes.
some weird room.
Yeah, and a few years ago when they showed up to our main meetings, we started hearing these lectures. We looked at each other and said, I don't know what this guy's talking about. This makes no scientific sense. But, this was before the adolescent onset gender dysphoria wave. Well, all right. I don't know what he's talking about. He's certainly not making a lot of sense. This does not sound scientific. So we're just going to kind of ignore this for now. Because it's not directly impacting me. But that was a mistake because now it's impacting everybody.
Do you perceive that there's a problem for people to even do a presentation on the stuff that you've been sharing and speaking about? Could you get a slot doing the counterpoint?
At the Endocrine Society or at these major societies? No, it's been asked, and it's been, and there are other kind of academic, right? So I'm a community endocrinologist. I'm a regular, one of 5,000 endocrinologists in the country. Mm-hmm. So I don't have an academic position. There are academic endocrinologists who would be willing and exceptionally able to tell the truth about the medical literature regarding gender affirmation therapy. But that's not been done so far, and it's a real problem. So that's the second. So the first is the docs don't have the education. The medical societies essentially will only allow for conversation after you agree that puberty blockade, cross-sex hormones, and sex reassignment surgery are the treatment for gender dysphoria.
That doesn't sound scientific whatsoever.
That's right.
Anti-scientific.
Yeah, and that's why this is very difficult right now. Because we have historically trusted these organizations to provide us with accurate information. Mm-hmm. and they're not in this situation. They are not actively generating debate, and it's a real shame.